Okay, so welcome to Labor and Delivery class number 2. We're going to go ahead and get started. I'm so excited and honored to be here with you tonight, and congratulations again. You are making your first A-plus parenting decision by attending prenatal education courses. This is class number 2 of a 4-part series, and thank you for being here. We're going to start off the way we always start off. I'm going to read this disclaimer out to you. You can follow along as I read. Our goal is to provide you with accurate, current, and unbiased information that will enable you to make realistic choices during your childbirth experience. Please note the use of any photographic, voice, and/or video recording devices are not permitted during the webinar. You agree not to reproduce, modify, use, publish, copy, or distribute any content of this webinar class. This webinar is not intended to be used for diagnosis or treatment or as a substitute for consulting your healthcare provider. Always seek the advice of your healthcare provider with any questions you may have regarding a medical condition or health concern. Although we strive to include all types of families, the words woman, mother, man, father appear in our webinar. We also alternate between he, she, and they when referring to a baby. We do not use these terms to be disrespectful to individuals who identify differently. Thank you again for joining us today. I'd like to point out that due to this being a live Zoom session, we may experience some connection interruptions. Should this occur, please be patient with us for a couple of minutes as our IT department troubleshoots the issue. Waston is pleased to partner with Tummy Talks to offer you these free live webinars, and Tummy Talks is a division of CBR, which stands for Cord Blood Registry. And we're actually going to talk a little bit about what that is and its significance to you tonight, but that's definitely not all. So my name is Letitia Gordon. If you haven't met me since last week, I'm a registered nurse. My primary area is labor and delivery. I'm also a doula. I do work for North Dallas Doula Associates. I am in the state of Texas. I'm a childbirth educator, which is why I'm here with you tonight. I'm also a lactation counselor because I just can't get enough of mamas and babies, and a previous mental health professional. So I actually do have a master's in psychology, and nursing was a career change for me. I've been married. Oh, I still didn't update this. I've been married for 9 years, and these are my two boys. They are 7 and 4 now, Noah and Jonah, and they are the best job I've. So today we are going to talk about birth plans. We're going to do newborn stem cell preservation. We're going to talk about your pain relief options. We're going to talk about some medical interventions that you may encounter. And then lastly, tonight, we're going to talk about the C-section. Okay, so Wasson is the clinic that you all are probably patients of. This is just a reminder of who we are and who is providing this lecture series tonight. Remember that the website and the patient portal are resources for you, so please look to that if you have any if you're in need of any resources. All right, so moving on to the birth plan. So the birth plan is a roadmap of your desired labor path. It's not inflexible or set in stone. I actually like to use birth preferences more than I like to use birth plan. So birth is so unpredictable, which is really going to set you up for parenthood. Parenting is more of a ride than birth will be, but it's still a beautiful ride. This map is an excellent analogy because roads can have detours, they can have blocks and straight up closure, but we have one end goal, which is the birth of your baby, healthy and safe, right? Your plan helps you with detours you may encounter and serves as a way to get you back on track, with the goal being healthy mom and healthy baby. It's also a means of communication with your provider and delivery team. So I recommend that when you start to create your birth plans, that you start discussing them with your doctor as well, your OB or your midwife. So creating a birth plan, what do you do? Let's watch a video on how the birth plan was presented and some things that they included.
Every birth experience is different, and no one can predict exactly how a birth will go. So it's best to be prepared. You can create a birth plan that outlines your preferences ahead of time. This will be a good communication tool that guides your decision-making process during birth. It helps you think about the birth experience you want, including how you might handle unexpected medical procedures. Be open to the fact that you might change your mind during labor, or there could be an unexpected medical issue. So it's a good idea to keep your birth preferences flexible. It's important to discuss this with your healthcare provider and labor support team during pregnancy.
And so we might say, okay, we can certainly do that for you.
Right.
But would you be willing to try this first?
Sure.
Okay?
Okay.
Okay.
Do you do a birth plan also?
Yeah.
Okay.
This is a secondary story.
Great.
Yep.
When you go to the hospital, bring your birth plan and share it with your labor nurses.
Okay, so you should start off by checking with your delivering hospital for a copy of the birth plan that they use. If they don't have one, that's fine. You can create your own. And since everybody is delivering at different hospitals, unfortunately, I don't have a sample birth plan available to forward along. But your delivering hospital is the best place to start. I actually used to work at a hospital that had a birth plan that mirrored the admission assessment, and it made things go by so quick. So some things that you should include in your birth plan. You want the name of your support person, along with their phone number, as well as any doulas or anyone else that's going to be present at the birth with you. This could also be a way that if you're not wanting additional family members to be there, but they're bogarting their way in, if you put this on the birth plan and highlight it for your nurse can be the bad guy and say, hey, we're not taking any more visitors. Any positions or comfort techniques that you'd like to use. We talked a little bit about positions in the last class. We also talked about laboring positions, and we talked about birthing positions as well. So think about what's important to you. What position, did it resonate with you that, you don't want to push on your back, you like pushing on your side. Pushing on your side is actually best for preventing tears. So I would highly recommend that you put that in your birth plan. Think about the amenities provided versus what you need to bring to the hospital. Learn about what's offered. So I recommend taking a hospital tour so do they have birthing balls? Do they have peanut balls? Do they have these things to help you progress in your labor, or is it something that you're gonna need to bring yourself? Do you want to use pain medication? So we're going to talk about your pain relief options today, and whether or not, whether or not you want to use them is up to you. If you choose to go unmedicated, I do recommend that you do keep an open mind, and it's still important to learn about your options. If you don't learn about your options, you don't have any. If you're planning to breastfeed, you want to include that so the nurse knows that they need to give you an extra hand. Or also, if you're not planning on breastfeeding, if you're planning on formula feeding and you don't want to use the hospital issued formula, you need to bring your own formula and also the things to mix it. I had a family once bring in some really nice formula that was imported from like Germany or something like that. But we had no sterile water and it wasn't available in the hospital for to mix the baby formula with. And so, they weren't able to use their home formula, and that was the formula that they had chosen for the baby for their first year. So if you're planning on doing something like that, make sure you have all the tools that you need to be able to feed it to baby as well, because the hospital may or may not have it. If you're planning on circumcision and other newborn procedures, we're going to talk about newborn procedures in the next class. So I will pitch questions for that to the next class, and I'm not going to go in too deep about it, but you can just make a note that, if there's any newborn procedures that you don't want to include, like the vitamin K shot, erythromycin, and the hepatitis B, or if you're okay with all of them, you can put them onto your birth plan as yes, I want all of this, or no, I want this, and that sort of thing. And then if you thought about cord blood banking and cord tissue newborn stem cell preservation, you put that into your birth plan too, because there's some extra blood collection and things that we have to do at delivery in order to get that processed. So the birth plan should help you feel confident during labor. It doesn't need to be too detailed or it likely won't be effective. I really like to break birth plans up into more like categories instead of checklists. So things, for example, environment. How do you want your environment to be? If there's any social aspects, mentally, where do you envision your birth? So more so of a birth preference plan and an envision of your birth than it is a list of things. This is what I want and don't want. When you get into having a list of things that you want and don't want, you're setting yourself up to be disappointed if it doesn't go your way. So that's the whole point of that. All right, so now we're going to hop into cord blood and cord tissue preservation. I'm going to take a few minutes to talk about cord blood and cord tissue preservation, what it does, and the options you have as a new parent in this progressive field of medicine. As healthcare providers, it's our job to ensure expectant parents are provided with information about what their options are regarding their baby's cord blood and cord tissue so that all pregnant parents can make an informed decision that is right for their family. I truly believe that education gives you back control and subsequently reduces anxiety. So I feel like it's better that you know than not know at all. So we'll watch a video. Dr. Rodriguez is going to explain this better than I ever could.
Hi, I'm Dr. Ali Rodriguez, an OBGYN and physician, and I've delivered thousands of babies. I know you are facing many important decisions at this time in your pregnancy. Today, I hope I can help you with the decision of preserving newborn stem cells from your baby's umbilical cord blood and umbilical cord tissue. Your baby's umbilical cord is made up of tissue and contains blood. Are rich sources of stem cells, which can be collected at birth and preserved for potential future medical uses. Cord blood and cord tissue can be easily collected immediately after your baby is born, without risk or pain to you or your newborn, in both C-sections and vaginal deliveries. Stem cells are considered the body's master cells because they have the ability to become the different types of cells in the body. The stem cells from cord blood can become red blood cells, white blood cells, and platelets. The stem cells in cord tissue can become connective tissues like cartilage, bone, skin, and fat. Preserving your newborn's cord blood and cord tissue today may give your family opportunities to access stem cell treatments in the future. It's important to learn about the current uses and also the potential future uses of newborn stem cells so you can make an informed decision before your child's birth. Ideally, I recommend that you look into your options and make a decision in your second trimester, since this will allow you time to be prepared if your baby is born before his or her due date. Today, cord blood stem cells are used in transplant medicine where a person's own stem cells or a donor's stem cells are used to regenerate a patient's blood and immune system. Currently, stem cell transplants can be used in the treatment of more than 80 conditions, such as leukemia, lymphoma, sickle cell anemia, and some immune and metabolic disorders. Beyond the current uses of cord blood stem cells, research in the field of study called regenerative medicine is looking at using stem cells to help repair and regenerate damaged tissue to help the patient's body heal itself. Some of these studies are exploring how cord blood stem cells may play a role in regenerative medicine. Many clinical trials are underway worldwide, investigating the use of cord blood as a treatment for conditions that currently have no cures, such as cerebral palsy and hearing loss. In many of these studies, the child's own cord blood is used for experimental treatment. A newborn's umbilical cord tissue is a rich source of another type of stem cell that may help repair and heal the body in different ways than cord blood stem cells. These cells are currently being evaluated in clinical trials as a potential treatment for heart disease, stroke, and spinal cord damage, among other conditions. This research is exciting, but it is important to note that the research is in its early phases. Stem cells can be collected from multiple sources in the body, such as umbilical cord blood, umbilical cord tissue, bone marrow, peripheral blood, and adipose tissue. Newborn stem cells have unique qualities and advantages, and the collection process is simple, safe, and painless. Cord blood stem cells are biologically younger and more flexible in terms of their matching requirements compared to adult stem cells. Because of these properties, there is less risk of certain complications when cord blood stem cells are used in transplants. Preserving stem cells at birth stops the clock, protecting the cells from aging and being exposed to environmental factors and common viruses that can decrease their function. When stored, a cord blood sample is readily available when needed and minimizes delays to treatment when a patient needs an immediate transplant. If you decide to save this valuable resource, you can preserve your newborn stem cells for your family's exclusive use or donate them to a public bank if your hospital has access to one. Otherwise, the cord blood and tissue will be discarded after delivery. I encourage you to really think about your options and preserve the cells with a family bank or donate them if possible to prevent these potentially life-saving cells from being thrown away. The collection process is simple once you've made your decision to save your baby's stem cells. If you choose to enroll with a family bank, you will receive a collection kit in the mail or from your healthcare provider. Bring your collection kit to the hospital with you and give it to your labor and delivery nurse. The collection happens immediately after birth. Once the umbilical cord has been clamped and cut, the remaining blood is drawn into the collection bag. If you elect to preserve the cord tissue, a segment of the umbilical cord will also be collected. After the collection, your healthcare provider will give the kit back to you. You will call the medical courier listed on the kit. They will pick up the kit from your hospital room and transport it to your family bank. I hope the information I've shared with you is helpful in making your decision about preserving newborn stem cells. If you have additional questions, I encourage you to speak to your healthcare provider or childbirth educator to learn more about cord blood and cord tissue stem cells. This is a very exciting time for you. Congratulations and enjoy it.
All right, so to recap, there's only one opportunity to store your baby's cord blood and tissues, and that is at birth. So, cord blood is the blood left behind in the umbilical cord and the placenta following the birth of baby. It's a rich source of a type of stem cell that has been used for the purpose of transplant for actually over 30 years to treat life threatening conditions such as blood cancers, solid tumors, immune disorders, and metabolic diseases. Over 40,000 transplants using cord blood have taken place worldwide. Additionally, the use of cord blood is being explored in the field of regenerative medicine to stimulate tissue repair and regeneration to treat conditions such as cerebral palsy, autism, type 1 diabetes, among others. Cord tissue is another option available for parents to consider storing. Cord tissue contains a different type of stem cell called mesenchymal stem cells, which are found in the Wharton jelly surrounding the vessel. Many clinical trials are underway exploring using these cells to treat conditions like osteoarthritis, lupus, and spinal cord injury. They hold great potential in the regenerative medicine field because of their anti inflammatory and immune modulatory properties. Your baby's stem cells are a perfect match to, to the baby from whom it's collected and may be a perfect match for siblings. While a baby is a 100% match to their own cord blood, they cannot use their own cord blood in a stem cell transplant for genetic conditions, so conditions that have something to do with their genes. They may be able to use their own cord blood in stem cell transplant for certain acquired conditions. And I will say, since we talked about cancer, that 95% of cancer is acquired. It actually is not genetic. Many of the clinical trials for potential future treatments have required the use of a baby's own cells. Full siblings have a 75% chance to be at least a partial match to a baby's cord blood stem cells and are the most likely individuals in the family to use a sample for a transplant. Biological parents are always a partial match to baby's cord blood stem cells, but would likely require higher doses of stem cells for a transplant than are typically collected from cord blood. Cord tissue cannot be used for stem cell transplant, but is being investigated for potential use in regenerative medicine. Evidence suggests that cord tissue may not require the same matching as cord blood and could potentially be used by the baby themselves or any first or second degree relative of the baby. So, some cool things in regenerative medicine that are going on right now. This is an area of medicine aimed at replacing or regenerating cells, tissues, or organs to restore or establish normal function. Researchers believe that regenerative medicine treatments have potential for many common conditions. See a lot of chats going on. Let me see. Okay, wait, just some questions. So we'll hold them until we get to our question break. As the population ages and the life expectancy increases, researchers are increasingly interested in regenerative medicine to heal or repair damage of the body. Researchers all over the world are investigating the potential benefits of using both cord blood and cord tissue stem cells to treat a variety of common conditions such as Alzheimer's disease, diabetes, osteoarthritis, organ repair, stroke, spinal cord injury, cerebral palsy, and autism. If proven effective for these common conditions, the likelihood of your family utilizing these cells would drastically increase. There have been more than 500 clinical trials aimed at expanding the uses of and creating new therapies with stem cells from cord blood and tissue. So, if any of these are in your family, I urge you to consider cord blood banking. Okay, so what are your options for banking? First, you have the family bank. So this is where your cord blood is stored for a fee for exclusive use by your family. I'll bring up a number here in a minute if you would like to talk with Cord Blood Registry to learn more about their current offers and promotions. Their phone number, I'll also give that to you as well as the website here in a second. They are going to be offering you a special discount for attending this class tonight. So if you are interested in learning more or you want access to that discount, I'll ask that you put your just interested in the chat box and with your email and phone number, and they will get back with you. The other option is public banking. You can donate your newborn's cord blood to a public bank and help increase the national supply of cord blood stem cell samples available to patients who need a transplant. But it's unlikely that the cord blood you donate will be available to your family in the future if needed. In most cases, donation is possible only if your delivering hospital has a program affiliated with a public cord blood bank. And so there's no way for me to know, honestly, if your hospital is one of those hospitals, but that could be a question that you ask on your hospital tour that I do recommend you go on. Currently, public banks don't offer the option to donate cord tissue. The other thing that CBR offers is the Newborn Possibility Program, and they offer cord blood and cord tissue processing and storage at no cost for 5 years for families with an eligible medical need. If you choose not to bank, your baby's cord blood is discarded at the hospital. There's literally going to be a red trash can in the room, and we will just throw it away. All right, so we've gotten to our first question break. So this is questions on your birth plan. Like I said, check with your delivering hospital for a copy that they use because likely it will be helpful with your admission process. And also your questions on cord blood and cord tissue and newborn stem cell preservation options. I'm going to give you a few seconds to put your questions into the chat. I do, as always, ask that you include your email or phone number in case I don't get to your question. I've already got 10 questions in the chat. And that's all we're going to have time to answer today. So if you don't get your question answered, I want to make sure someone from our team gets back to you. So please, please, please make sure you put your email and phone number in the chat box as well. Okay, so let me start answering some of these questions. I really just needed to catch my breath for a second. So someone asked, can you tell me where I would find the birthing plan on the hospital website? So this is on, remember when whomever your delivering hospital is, you want to go on their website and just see if they have a birth plan available. If you can't find it, I would ask, when you go on your hospital tour, if they have a copy that they like to use or if they've seen some that they, particularly like for that you could, kind of make a template off of. But if not, it's okay. You can go on the internet and literally type in birth plan or birth preferences, and it will bring up tons of stuff for you. And you can kind of mix and match whatever plan you would like. I do recommend that as you're listening to these classes too, that you jot down things that you think that you would prefer as your birth experience, so that you can start making your plan now. So someone's asked about delayed cord clamping. Can they still do cord blood banking? So yes, it is possible to delay clamping and still bank newborn stem cells. Most OBGYNs do recommend a 30 to 60-second delay, and that has shown that has the significant impact on cord blood banking. Um, there is no approved use for cord tissue stem cells. Delayed cord clamping does not impact the collection of cord tissue, however. So those who choose to delay for, like, say, until the cord stops pulsing or until the cord goes white, you can still bank cord tissue. Almost everyone has an option to bank at least something. So how do you find a reputable bank? Um, you want to choose a bank that is accredited. So CBR does have AABB accreditation, which means that they've gone out and basically gone through these extra, things beyond FDA approval to say that they're accredited. So that's how you know kind of that it is top of the line. And you should look at that for anything that you do. Always look for accreditation in anything. Um, so CBR isn't the only one out there. So I do, do your homework and find, one that's going to be best for your family. Um, so yeah, that's all I got with that. I have heard that sometimes the child cannot use their own cord blood. Okay, so you probably heard me say that the child may not be able to use their own, and that's for genetic or hereditary diseases. And this is because there's already something up with the genes, so obviously we wouldn't be able to use that. But it's more often that cord blood is used by a sibling than it is the child themselves. But like I said, if you have any of those conditions in your family from that list of regenerative medicine, that I recommend that you kind of do look into this. So when will they review the birth plan with me? Usually this is on admission into the hospital. So typically you'll come into the hospital and nurse will get you in, they'll get you on the monitor, they'll start talking to you, and that would be the point where you could give the nurse the birth plan. This is also something that your partner can do. I highly recommend that. So whomever is going to be supporting you during your labor, I would say have them be responsible for having copies of the birth plan and giving them over to whoever needs to see it. How long is cord blood able to be stored? So the studies have shown that they have been stored for over 20 years and that they're still viable. So they could last your child into adulthood, and which is really what we want. And so we think that they can be stored for many decades as long as they're maintained in proper storage. Let's see. So who can use the samples? So really, it's the whole family. So like we said, a baby is 100% match. And then a sibling is going to be a 75% match. And then parents are always going to be a partial match as well. And then tissue actually may not require the same matching as cord blood and could potentially be used by the baby themselves or any first or second degree relative of the baby. So there's a lot more that we can do with the cord tissue. This one always cracks me up. I get this question every time. Can I store newborn stem cells in my freezer at home? No, because it has to be in cryo storage. And like I said, in order for doctors to be able to use it, if you needed to use it, it has to be in kind of like this contained area that has, you know, um, FDA approval and things like that. So it has to come from a very specific, from a bank in order to be used. It can't just be from your freezer at home, unfortunately. Although that would be nice, unless you have a freezer that can get to 196 degrees Celsius. Yeah, there's no way that you can save it yourself. How many times can cord blood and cord tissue samples be used? So with cord blood, we expect to get one, maybe two treatments out of it. But with cord tissue, it has the ability to be expanded. So we expect that we can get multiple uses out of cord tissue. So if I want to do this, when do I have to decide? At any time. So you have any time from now until honestly up until you deliver your baby. Most hospitals will have kits available, although I don't recommend you depend on that. I had a patient once that we had literally just ran out of the boxes and they had twins and they planned on banking for both of the twins. and we were out. And so I felt so bad for them because they really wanted to do it, but we didn't have any at that time. So don't let that be you. If you're even thinking about this, contact CBR, get your kit shipped to you, so that, you're prepared. And if you decide not to do it, then so be it. So, of course, everybody wants to know. I've been kind of grazing over it. Everybody wants to know the cost to store. And so, unfortunately, I do not have that information. But if you'd like that information, you can call this number or go on this website. And like I said, if you're interested, I believe they said if they get 10 interested, they will give a very special discount for those who are attending tonight's session. Phew. Okay, make sure you include your name, phone number, and email if you are interested. All right, so moving on. So understanding your pain relief options. So just a quick, I'm just gonna quickly say this because most hospitals have not been using the nitrous oxide, so we don't have a slide for that. But it is making a reemergence. So I definitely encourage you to do research into what is available at your delivering hospital, as well as what your doctor prefers. So the nitrous oxide uses a mask that you inhale, and it has a tube that mixes oxygen and nitrous oxide, and it dulls pain and eases anxiety. It's also out of your system really, really quickly within seconds as soon as you remove the mask, which is really important if delivery is imminent. And we'll talk a lot more about that in a few slides here. So first off, what we'll talk about is analgesics. So this is your morphine, fentanyl, Nubain, Stadol, and Dilaudid. So what you've probably heard of as narcotics, and it probably scares the heck out of you, but let me tell you that these are dosages that are appropriate for you. They really are effective for labor, and oral medications do not work in labor. I'm telling you, they won't even take the edge off for labor. It has to be IV medications. Now, you do not have to do IV medication. So you have IV medications available for pain relief, you have nitrous, and you have the epidural. And then you also have comfort measures, which we don't really get into tonight. But like I said, if it is your goal, I said in the last class, if it is your goal to be unmedicated, I recommend that you take a childbirth education class that is geared just for that, so that they can teach you and your partner the comfort measures for being unmedicated. Okay? But just some information so that, again, you know your options. Every hospital is different with what they offer, so I would recommend that you, on your tour, ask what's available to you. There's actually at my hospital a Stadol and Nubain shortage, so we don't have that available. So people who come in with their birth plan and they have this in there, I'm so sorry to disappoint them because we're at a shortage. So make sure you ask if you're interested in any of these. So these drugs are administered through your IV. It's a systemic medication. It affects the whole body and it lessens pain without taking the numbness off. So morphine has been used for many years in labor, although in my experience, it hasn't been the most effective. Most effective for labor to kind of just get that edge off to me has been fentanyl, but that's just my experience and everybody is different. There's usually a cutoff for this option, and that's usually about 6 to 7 centimeters because of the effects on babies. So this is a systemic medication, meaning it does go into the bloodstream, it does go into the placenta, and it does cross the baby. So, that's some things to consider when making your choices about these things. It usually does not last very long either. Typically, you probably would get maybe an hour of relief. And so you usually will have to have multiple injections if this is your, treatment of choice. And some of them have time limits on them. So, sometimes they last about an hour, but you can only have them every 4 hours. So it allows you to kind of get some rest, but it's not going to take the pain all the way away. And we'll talk more about the advantages and disadvantages. I'll have you watch a video about a woman who decided to use the analgesics in her labor.
Breathe.
Janine's labor started yesterday afternoon. She labored at home for several hours before it was time to go to the hospital. It's now early morning and she is exhausted and considers pain medication. She requests an analgesic, which is a medication that affects the whole body. It dulls pain sensations, but does not get rid of the pain completely. The analgesic is either injected as a shot in the thigh or buttocks, or given through an IV line.
You probably have just enough time to have one dose of some medication in your IV. That would just take the edge off. So it's your choice as far as what you want to do.
So the reason why I was open to the IV drug is because the doctor had said that it was a way to kind of take off the edge. And I needed to take off the edge. And I felt like my breathing was doing pretty good, but it was just so painful.
So after Janine took the IV drug, I experienced her as more calm, more collected. Even though she was still in pain, she wasn't as stressed. So I noticed a difference.
It's recommended that you consider analgesics earlier in your labor in order to reduce these effects on the newborn. For this reason, many hospitals have policies regarding when they allow you to receive analgesics during labor. For Janie, the analgesic wears off and she progresses into pushing and birth several hours later.
Good job. He's coming. He's coming out. He's out.
Okay.
His head's out.
Look down, Skylar. Look down. Look down. Open your eyes. Open your eyes. Open your eyes.
Look at him. Look at him.
There you go.
Good job.
Up here.
When the baby came out, it was a relief. I'm like, okay, yes, it's done. We did it.
Oh, yeah.
You know, I wanted to look at him. I wanted to touch him. I wanted to hold him and see if he was okay.
So these medications do require an IV. So if you were thinking that you didn't want to have any lines during your labor, if you're considering the IV medications, you do have to have IV access. So some advantages and disadvantages. The advantages are that it can be given pretty soon after requested. It provides very fast pain relief, usually, within 15 or 20 minutes, sometimes even less. Sometimes it's instantly, depending on, kind of how your body responds to things. It doesn't numb your muscles, so mobility is still possible after the drug has worn off. So initially, when we give this, we do want you to kind of stay seated just because, it can make you dizzy, can make you lightheaded. So we don't want you to fall. But once it wears off, you're back to being able to move around. Unlike the epidural, once you have the epidural, you're kind of stuck in bed. And there is not really a such thing as a walking epidural. Not sure who put that rumor out there, but it doesn't exist in my experience. So the disadvantages are that it does not provide total pain relief. It may cause drowsiness, disorientation, itching, or nausea. It can slow breathing or lower blood pressure, and it may inhibit mobility while in effect. So the side effects for baby is that baby may be sleepy if it's too close to delivery. Baby may be sleepy and because of that have difficulty breastfeeding at first. It may slow breathing down and reflexes temporarily. So I had a patient once that was given an analgesic medication very close to delivery. She progressed really, really fast. And so then the baby came out and it had very slow breath. So I had to go to the NICU for a little while to kind of sleep off the medication. So just be aware that too close to delivery, we cannot do these meds because of those effects on baby. So we avoid just prior to birth to reduce these effects. And again, birth is unpredictable, so we never know. So that's why once you get past a certain point, usually about 6 to 7 centimeters, that's why we won't use them after that point. So the epidural anesthesia, this is administered by an anesthesiologist. It's a regional anesthetic that numbs the sensations in the uterus, abdomen, and lower back. So it's not systemic. It's going in the region it bathes the nerves and numbs the sensation so that you do not feel pain. You'll still feel pressure with contractions on the pelvic floor, and sometimes it can be pretty intense contraction or pressure. So if you thought you weren't going to feel anything at all, that may or may not be the case. Some people don't feel anything at all, and some people still feel that pressure, and some people feel the pressure a lot. So just be aware of that. Typically, we like to wait until active labor is established, so usually about 4 to 5 centimeters. You have to have IV access. You will be given fluids along with this because the epidural dilates the blood vessels and blood pressure drops, which baby does not like that. Typically, before we can get started, we need your labs back. So this is not something that you can instantly get as soon as you arrive to the hospital. What I've noticed is that for women who do want medications during labor, when they arrive to the hospital and they arrive in pain and things like that, as long as they're under, that 7 centimeter, 6 to 7 centimeter mark, they'll do the IV pain medication while waiting for their epidural. So you can kind of mix and match these. Once you have the epidural, there is no more IV pain medication. We use the epidural only, and any additional medication that you need will be, well, any additional pain relief that you need will be placed in the epidural. So if the epidural, you start to progress and you need more medicine from the epidural, the anesthesiologist will put more medicine in your epidural catheter. They won't put it in your IV. So your IV is not used anymore after the epidural. Usually, this is administered while you're sitting. So just like she's sitting like this. So one of the only requirements for an epidural is that you've got to be able to sit up and you've got to be still. If you progress too far where you can't be still and you can't sit up, an epidural may not be an option for you. I say this to say that some people think that there's a stopping point for when you can get your epidural. Like if you're 10 centimeters, you can't get it, but that isn't necessarily true. I have had women to get epidurals at 10 centimeters dilated. Not ideal because you could really just push the baby out after you've made it that far. But if you really, really want that epidural, it can still be done. But like I said, you've got to be able to sit up and you've got to be able to sit still. After this, you won't be able to get up because you won't feel your legs really. So a catheter is inserted into your bladder so that your bladder is kept out of the way because your bladder can, get where if I wish I had a picture of the anatomy of your belly, but your baby is pressed up against your bladder, and if your bladder is full, it can prevent you from progressing in labor. So we want to make sure that your bladder stays empty. And that goes if you're unmedicated as well. Make sure that you're constantly using the bathroom and emptying that bladder. So the side effects on baby are related to blood pressure. Again, it's not systemic. So it's not anything about the medication going to baby. Has nothing to do with that. And if any side effects happen, it's because of your blood pressure dropping. And that's one of the reasons why we do give you IV fluids. So just, lactated ringers is typically what we use to help keep your blood pressure up. You can sometimes request a consult prior to your epidural with the anesthesiologist. They should come in and talk to you about the risks and benefits beforehand. But if you really, want to talk more about things, you can request a consult if you have concerns. So the epidural procedure, we'll take a look at that.
As you follow Marimar's birth story, you'll learn more about epidurals. She went into labor about 8 hours ago. Now she is dilated to 5 centimeters and requests an epidural.
The reason we chose to get the epidural was just really the exhaustion that I felt.
Marimar receives fluids through an IV before getting the epidural. The procedure is performed by an anesthesiologist or a nurse anesthetist and takes about 15 minutes to complete. To start, the anesthesiologist washes Marimar's back with an antiseptic cleanser. Then he injects a numbing medication into her lower back so she doesn't feel the epidural needle. This animation shows where the epidural is placed. You can see that the injection site is below the spinal cord, so there is almost no risk of the needle puncturing the cord during the procedure. This image shows you a closer view of the administration area. The center column is the sac that contains the spinal cord and spinal fluid. The gray area that surrounds it is the epidural space. To get into position, you will curl forward or hug a pillow to make more space between your vertebrae, which are the bones of your spine. The epidural needle is carefully placed between the two vertebrae and into the epidural space. A catheter, which is a thin plastic tube, is threaded through the needle. The needle is removed, leaving the tube in place. The anesthesiologist then injects a test dose of medication through the catheter. The catheter is taped to Marimar's back, and medicine flows through the catheter. It takes about 15 minutes to feel pain relief. Once the epidural is in place, Pain should be reduced by numbing your belly, lower back, and vaginal area. You may still feel a slight amount of pain, pressure with contractions, or pressure on the pelvic floor as your baby moves down. However, your baby won't feel any numbing from the medicine.
And afterwards, the contractions were pretty much back to how it was at the beginning. So I was able to get some rest after that.
Having an epidural brings about an immediate increase in using more medical equipment during your labor. You're continually monitored after receiving an epidural. In addition to fetal monitoring, the staff monitors your blood pressure and the amount of oxygen in your blood for the remainder of your labor. Since your legs might also feel numb, and you may not feel when your bladder is full, you'll need a urinary catheter. This is a flexible tube used to drain urine from your bladder. One downside to having an epidural is being stuck in bed and not being able to use more productive upright labor positions. But with the epidural in place, you can still move from side to side once in a while. Changing positions helps your baby rotate into position for birth.
So the part about not being able to have and be in upright positions is actually not true. I've gotten patients with epidurals into upright positions. I've gotten them into all fours. I've gotten them into supported squats. So it is possible to be in upright positions when you have an epidural. You're just not able to like stand and walk. But you can be in an upright position. So typically, this is where the epidural catheter is inserted, so nowhere near your spinal cord. So, low risk of anything going on there. It's removed typically, it's turned off usually after the baby's born and the placenta is out and repair is done. So, usually, if there are any lacerations that your doctor has to repair, the epidural will help you not feel any of that. So it's turned off right after all of that is done. And then a nurse will be the one to remove it once kind of 2 hours have passed and they know they're not going to need to use it again. So the effects don't fade away immediately after it's removed. It usually takes about 2 hours or so after it's turned off to get the feeling back in your legs. And removal is much easier than insertion. So the advantages and disadvantages. Advantages are that it's very effective pain relief. It allows rest and it does not affect mom's mental state. The risks are that it may offer incomplete areas of relief. I know we've all met somebody that their epidural did not work, and that is a possibility. It may lower blood pressure and cause fetal heart rate to drop. It may cause shivering, fever, itching, and or nausea. It may cause soreness or bruising at the administration site, and the rare but serious risks are listed on the consent form. Um, the effects on labor is that it does require continuous fetal monitoring. So if you were hoping to do, intermittent monitoring and, being able to move and get out of the bed, you won't be able to do that because you're going to be stuck in bed. So you have to have continuous monitoring also because of the effects that the epidural may have on your blood pressure and how that can affect baby. Because you're going to be staying in bed and you won't feel that you need to use the restroom, we're going to insert a urinary catheter, which is a little straw that's inserted into your bladder and drains the urine. Again, we want that urine to be constantly empty because if it's full, it's going to affect your labor progress. Epidurals can affect your labor progress. It kind of relaxes everything down and may slow down the contraction, so it could slow down your labor. And it may decrease your ability to push effectively just because you can't feel, but we have ways to mitigate that. So some tips for the epidural is to wait until you have regular contractions that are changing your cervix before requesting it. Periodically rotate from one side to the other. Your nurse is going to be pretty good about making sure you rotate quite a bit. So more than periodically. I'd say about every 30 minutes you need to be changing positions. And we have numerous positions available to help keep labor progressing even when you have an epidural. Once you're fully dilated, you should allow the baby's head to descend further down before pushing. So you're going to hear three different numbers whenever they are checking you to see how your labor is progressing. So first is the one you heard of, is just dilation, which is anywhere from no dilation at all to 10 centimeters dilated. Then there's effacement, which we talked about is that thinning of the cervix. So you have from not thin at all, so being thick, to being 100% effaced, which means that your cervix is gone. It's super paper thin. We can't even grab it anymore. Baby's head has emerged from through the cervix and, can come through. You can start really the pushing when you have that effacement gone. And then there's station. So station is where the baby is in the pelvis. So if baby is right at the edge of the pelvis, right at, if you feel on your bottom, you feel those bones there. If baby's head is right there, that's called zero station. Once baby goes beyond those bones there, then baby's at a +3 or plus +1 to +4 or 5 station. And so that kind of tells us where baby is in the pelvis. And the further baby is, so that you want a plus station before you start pushing. Because the further forward that baby is, the less time you have to spend pushing. So if baby's still at zero station and you have an epidural, you probably want to wait a little bit before starting to push. So I will take your questions on your pain relief options or anything that we've talked about tonight. You can go ahead and enter them in the chat. I'll mute myself for a little bit. Make sure to include your email and phone number. Okay, always a little less questions on this one. So someone asked, does it hurt worse to have an IV on the arm or in the hand? And do you get to choose where your IV is at? The hand is, you're gonna move your hand a little bit more. So usually that does hurt a little bit worse in the long run. Maybe not inserting it may not hurt as much, but in the long run it can hurt just because you move your hands. Arm is typically better. You do get some choices in where we put the IV. So, usually like if you've had an IV before and you know that it's done well in your wrist or your forearm or something like that, they'll try those areas for you. But typically they're going to put it someplace where you're less likely to bend it. Because bending it will cause your IV to occlude, and then you'll have all these noises, and you won't be getting the medication in because it's occluded. So they'll put places that you won't, bend, which so that means we kind of avoid things like the hand and in the elbow, so the inner side of your elbow where most people are probably used to getting that. So we actually avoid those areas because that's where you hold baby. Someone else asked how much is the estimated epidural cost? That varies by your insurance. So if you're really interested in that, you should call your insurance and ask them what the allowed amount is for your epidural, and that will let you know how much the epidural cost is because each insurance has a contracted rate with the hospitals. And so that's why, or that's how you can get that information. You got to get it from your insurance. Everybody's insurance is different. Do we know why epidurals sometimes don't work? Most likely it's based upon like the placement. So if it's not exactly in the correct spot, or if like your anatomy, like maybe you have some undiagnosed scoliosis, so your anatomy is a little bit different, that could be a reason why it doesn't work. One of the main things that I do if it seems like an epidural is not working is just get them to redo it. So that is an option to you if it's not working for you. Also, sometimes if you get a fever during labor, you burn off the medication really quickly. So that because you have a high temperature, right? So your metabolism is going fast. Sometimes that can cause an epidural not to work because it's working, but it's just your body is metabolizing the medicine faster than the medicine is going in. So in that case, we would just give you a higher dose of medicine and treat your fever. All right, just because I want to make sure that we get out on time, I'm going to go ahead and move on. So if you have any more questions, please, please, please include your email and phone number because at this point, it's likely that I won't get to all the questions in the chat. Okay, so some interventions. So some things that you may encounter before or during labor. See, these require informed consent. So no means no. And some things that you can ask when recommended for an intervention are the following. So the first one you should ask, so let's say for instance, our example is induction of labor. So the first thing you want to ask is what's the reason for this procedure? Why are you being recommended for induction of labor? Then you want to find out what does it involve. Um, so what are they going to do to induce the labor? So a lot of times I spend a lot of time when I'm initially admitting a patient, I spend a lot of time explaining the induction process. And that's something that really should be discussed with your doctor. So just know that it's not a quick like one and done. So if you may think that you know the induction process, even based upon talking to me tonight, you may think that you know the induction process, but it really does look different for every patient, and every doctor has their various ways of doing it. So you want to make sure that you know what that involves and that you know all your options involved with that. So if this it doesn't sound appeasing to you to come in the night before for cervical ripening and not get induced until the next day, you need to talk to your doctor about what else there is that you can do to help get your labor going. And not everybody needs to be induced. So we'll talk about who needs to be induced here in a few. So what are the risk side effects associated with this procedure? What could go wrong? That's a really important thing to know because if, you know, yes, your doctor does know best, but you still have some choices in this matters. Okay? It's still, it's your baby, it's your body. So, knowing the risk and side effects allows you to make choices on what you want to do with your baby and your body. What's the next step if the procedure fails? So if your induction doesn't work, what is next? So for some, that would be a C-section. For others, that would be going home and trying again another day. What are the natural alternatives to the procedure, including waiting? So what happens if we just wait? What are the risks of waiting or trying other alternatives? That's kind of the same question, but still, you get the gist. So what else can we do, including just waiting for things to happen on their own? If you don't know your options, you don't have any, like I said. So external fetal monitoring is another intervention you can kind of say in labor. Typically, if you have an epidural or pitocin is going, you're going to be continuously monitored, and it looks like this. So you have two monitors. The top one is measuring your contractions, and the bottom one measures baby's heart rate, and it's transcribed onto the paper on the right. So on the top, you can see the baby's heart rate, and on the bottom, you can see contractions, and the contractions look like these mountains on the strip. We call that a fetal monitoring strip. Watch a video about fetal monitoring.
Your healthcare provider will keep an eye on your baby's heart rate and the pattern of your contractions. To apply an external fetal monitor, the nurse wraps two elastic belts around your belly that hold sensors in place. The top sensor monitors how often you're having contractions, but not the strength or discomfort level. The lower sensor monitors your baby's heart rate. Both sensors are connected to a machine that displays this information and allows you to hear your baby's heartbeat. How often the staff uses these monitors depends on how your labor is progressing. Continual monitoring is only used when medically necessary, so most low-risk mothers will not need to be monitored all the time during labor. When you're being monitored, you may need to stay in a chair or in bed. However, many hospitals have wireless monitors that allow you to move around, which could help your labor progress. Also, some hospitals use a handheld device to monitor your baby. You can ask your labor nurse if the hospital has handheld or wireless monitors. Another way to record your contraction pattern and your baby's heart rate is with internal monitoring. Because this is more invasive, it's only used when it's essential to watch your baby's well-being and your contractions more closely.
So what I'd like to do, if you're okay with it, is try something with a monitor we put inside your uterus to see how strong your contractions are and what's really going on with your contractions.
Internal monitoring gives more accurate information than external monitoring. To monitor your contractions, a small plastic tube is inserted through your vagina into your uterus. To monitor the fetal heart rate, tiny spiral-shaped wires are gently attached to your baby's scalp. Your healthcare provider might use one or both of these depending on your labor situation.
Okay. There are sometimes wireless monitors that you can use as well. So if you really want to keep moving around and you want to be mobile, you can request a wireless monitor. Not all hospitals have them available, but most of them do now, and that allows you to be mobile and still be monitored. So, induction of labor. So, we kind of talked about this as an intervention before. And so, this is the process of starting contractions by artificial means to cause labor and birth. So, some reasons for that would be if the pregnancy continues too far past the due date. So, that means like 42 weeks typically. But each doctor kind of has their preference. So, talk to your doctor about when their hard stop is. For some, that's like 41 weeks. For others, that's 42 weeks. If the health of mom or baby is at risk if the pregnancy continues. So if there's something health wise with mom, say for instance, like blood pressure issues or gestational diabetes, that may be a reason to induce labor. If the bag of water breaks and contractions don't start, is another reason to induce labor. So if your water breaks and contractions don't start, which can happen, that would be a reason to induce your labor because the longer that we leave your water broken, the higher your chance for infection. And infection causes those fevers, and baby can be affected by that as well. So if your body is already close to starting labor, there may be some non-medical alternatives you can try. Definitely talk to your healthcare provider about it. So that includes things like membrane sweeps, which usually are done in the office, and there's supplements like red raspberry leaf tea that you can do as well. But always, always talk to your doctor before trying something like that. This on the right so shows a cervix. So this cervix, I would guess, is probably maybe 1 to 2 centimeters dilated. And so we need the cervix to be ripe in order for induction to be successful. So typically we would do cervical ripening the night before in order to soften the cervix and to get it ready for induction because if it's not ready, nothing will happen. So if we jump straight into induction, it won't work. So likely we have to ripen the cervix first, which means we get the cervix to efface and begin to dilate before inducing the labor. So that might sound really confusing, but bear with me, we'll get through it.
A week before Nakaya's due date, she develops high blood pressure. Her doctor recommends that inducing labor now is the safest option for her and her baby.
Packed my bags and I mentally prepared myself. Then I went to the labor and delivery and they hooked me up to the monitors.
Inducing labor means using medical procedures to start labor. There are several medical methods used to induce labor. Sweeping the membranes is one. This is when your healthcare provider separates the amniotic sac from the lower wall of your uterus in an attempt to trigger labor-causing hormones. Another way is using a mechanical dilator, which is a device that is inserted into the cervix and slowly expanded. Your healthcare provider might also insert a ripening agent against your cervix or give you an IV drug called Pitocin. This medication is similar to the hormone oxytocin, which women's bodies naturally produce during labor and birth. Inductions are more likely to be successful if the cervix is ripe, meaning it's ready for labor. A woman's cervix is considered ripe when it is soft to the touch, starts to thin, and begins to open. Your healthcare provider will examine you to see if your cervix has begun to ripen. Are you ready? Since Nakaya's cervix has not dilated yet, the midwife inserts a cervical ripening agent into her vagina. This is a tablet that will dissolve.
So it's this little tiny pill, and I put it in your vagina towards your cervix, and what it does is help soften your cervix so that when you do have contractions, your cervix will dilate and open. Okay? We can put that in every 4 hours. You have to stay in bed for 2 hours because we want it to dissolve and stay in your vagina. We don't want you to get up and have it fall out.
A cervical ripening agent alone might work to start labor, but in other cases, a cervix might not respond to the ripening medication at all. After spending the night in the hospital, Nakaya needs a little more help to get her labor started. So she is now given the IV drug Pitocin. Pitocin might be used after a cervical ripening agent has been given, as in Nakaya's case, or it might be used on its own.
Okay, so the video also said that you had to stay in bed for 2 hours after you have the cervical ripening, but that's actually not true. It's usually only like 30 minutes. But like I said, we don't know which cervical ripening agent will be used for you, so could be different. So just make sure you understand the risks and benefits and also the procedures before going through with something like that. So augmenting labor, this is the use of medications or interventions to speed up a stalled or slowing labor. And it should only be done if medically necessary because there are risks involved. So we don't want to do this just because we want to rush labor. Okay. If your labor does slow down, you can try walking and using upright positions to help strengthen contraction.
Nakaya's induced labor is now in full swing, and she requests an epidural.
All right, good to go. Success.
A few hours after receiving the epidural, her labor slows down. Augmenting labor means using medical procedures to cause stronger, more frequent contractions, with the goal of opening the cervix more quickly.
Okay, so you might feel pressure, like touching. Can you feel me touching?
Yeah. Am I doing good?
Yeah, you're 400.
Her midwife suggests breaking her bag of waters to try to strengthen her contractions.
And then I just kind of snag it with the end there, and it pokes a little hole. So you see that little.
Breaking the waters, or amniotomy, is often used to move labor along. It also allows the practitioner to assess the condition of the fluid. Breaking the bag of waters is relatively simple to do and doesn't hurt the baby. To most women, it feels similar to a pelvic exam.
Is it
It's
water?
nice and clear, yeah.
Okay, good.
Did you feel it?
Yeah. Well, I didn't feel it pop, but I felt it come out.
To break the bag, your practitioner makes a small, painless hole in the amniotic sac with a long crochet-type plastic hook. As the amniotic fluid around your baby's head drains, her head drops against your cervix, putting pressure on it. This should help to open the cervix. This added pressure also makes contractions feel more intense. Practitioners generally wait until the head is low in the pelvis before breaking the waters. There are risks for you to consider before agreeing to an amniotomy. First, it does not always shorten labor. Second, once the bag is broken, there is an increased risk of infection. And third, the lack of amniotic fluid in the sac may increase the risk of fetal heart rate issues. Miramar has not progressed any more since the last cervical check.
And the other option would be starting IV medicine to help your uterus along.
The Pitocin?
If you're okay with it, I would think it would be a good idea to pursue Pitocin.
Yeah.
Miramar discusses the benefits, risks, and alternatives to Pitocin with her doctor.
I was saddened to hear them, when they came in to talk to me about the Pitocin, weighing, the options and considering like what I wanted versus what, is best for me and my baby. We decided to just, go ahead with the Pitocin.
Pitocin, which is also used to induce labor, is a chemical made to imitate oxytocin, the natural hormone that triggers labor. Pitocin is usually very effective at starting or strengthening contractions. A pump controls the amount of Pitocin that Miramar receives through her IV. This allows the nurse to adjust the amount of medication as needed. Your baby's heart rate will be monitored continuously while you are receiving the drug.
Okay, so some methods summary that we've talked about. So some things for um, induction or augmentation. So induction, you could strip the membrane. So it just means separating the membranous sac from the cervix. That releases prostaglandins and can start contractions and start the cervical ripening process. And then there's the medicine, so cervical ripening agents. Most of the time that's going to be Cytotec or Cervidil. Cytotec is the little pill that's placed in the way back of the vagina and helps the cervix to soften and begin to dilate. And then Cervidil is like a little, it's literally like a little, it looks like a very, very small tampon that's placed in the back of the vagina. It stays there. It actually draws water from the cervix and causes the cervix to thin out and dilate. And it's left in for 12 hours. Definitely learn about the risks about and side effects of those because some of them can be pretty uncomfortable. So being aware of those beforehand can help you mentally prepare if that's something that you're going to have to go through. Then there's the Foley catheter or the mechanical dilator. So this is literally, we call this a double bubble. It's literally a straw that is inserted into the cervix and it puts pressure. So this is what would happen if baby was engaged in putting pressure on the cervix. It puts pressure on the cervix, causes more of that hormone prostaglandin to release and causes contractions. It does not hurt baby. It's literally like a little pillow for baby. And it comes out on its own. And usually when it comes out, it's filled with water or sterile water. Usually when it comes out, you're about 4 to 5 centimeters dilated. Now, one thing I will say is that when this goes in and when it comes out, you're 4 to 5 centimeters dilated, but usually your body has not really started labor yet. So you may stay 4 to 5 centimeters for a long time. So just be aware of that. Um, all of these, it's likely that Pitocin would be started afterwards. So they ripen your cervix, and then to induce your labor, they'll start Pitocin. And so this Pitocin can also be used for augmentation. So uh, if your labor slows down or if there's some reason that they need labor to speed up, like maybe baby isn't tolerating labor or something of that nature, or you've developed a fever, you've developed an infection, and we need to just get labor going, Pitocin would be started. And these help to increase the frequency of your contractions and also the intensity of the contractions. There's also the amniotomy, which is just breaking the water, and that allows for a baby's head to come down and really press on that cervix and again cause that hormone prostaglandin to release. So we talked a little bit about how you need IV fluids if you have an epidural or you're wanting IV pain medication. And so IV fluids help maintain adequate blood pressure if you have an epidural. That's also how we deliver Pitocin or antibiotics if any other medicines are needed. And it's also how we prevent dehydration and treat dehydration. So a lot of times if you come in and you've been in labor for a while, it's probably difficult for you to continuously drink water like you should. And also, if you're really, really nauseous, like you've been vomiting a lot, which does happen during labor, then IV fluids are going to be recommended to help keep you hydrated because we need hydration. Your uterus is a muscle, it needs water to be able to contract effectively. And baby also needs you to be hydrated as well. Sipping water and juices frequently or sucking on ice chips can help prevent that dehydration. All right, so now we've gone through all of the kind of labor interventions. So now our second stage interventions. So these are used if the baby can't get through the birth canal. So baby can't get through the vagina. Or it could be due to anesthesia. So it could be due to the epidural. It could be you've just had a really long labor, so you're exhausted. Or it could be that baby's in a wonky position. So like not in a OA position, like a anterior position like we saw in the last class, or maybe the size of baby that causes baby not to um, be able to get through like it should. And this is only used if baby needs to be born quickly due to distress, which usually is manifested by a sudden change in heart rate, usually a drop in heart rate. So using upright pushing positions and following your body's natural pushing urges may reduce your need for these interventions. So you may be thinking, well, how am I going to feel my body's natural pushing urges if I can't feel my contractions because I have an epidural? Well, I recommend that you feel your belly. So your belly is still going to contract. You're still going to be able to reach down and touch your belly and feel when you're having a contraction. And you should definitely learn to do that because that's going to help trigger when you should push. So when we are pushing, which is the second stage, when we are pushing, we want to push with a contraction. So we have the power of the contraction and the power of your pushing to get baby out. So some second stage interventions include the forceps and the vacuum extractor. So forceps, they kind of look like these salad tongs. They're placed on both sides of baby's head. And what happens is you'll push and your doctor will pull. Not everybody uses forceps. What I see most often in this day and age is the vacuum extractor. So this is a little suction cup that's placed on the top of baby's head. And then same thing, same concept. You would push and doctor would pull. There are some risks. So there can be bruising on the baby's head, and there's typically more tearing with these types of procedures because we are, kind of forcing baby through instead of, baby naturally coming through the canal. And like I said, these are only used if absolutely necessary. So if they're presenting to you that they need to use forceps or a vacuum extractor, that means that baby's likely in distress and we just need to get baby out. There also can be temporary nerve problems in baby's face with the forceps just because of the pressure. They do resolve on their own, however. So episiotomy, this is an incision that increases the size of the vaginal opening at birth. A local anesthetic, if you don't have an epidural, a local anesthetic is injected before the procedure so that you don't feel it. It actually does not substantially shorten the birth of the baby's head. So some doctors will do this to like extend a tear. So if you're tearing naturally, they may just, put in do this in order to have the tear go more straight, which really isn't a reason to do that. So I would ask your doctor if episiotomy is something that they use regularly, and then learn the risk and benefits related to that. This type of incision becomes infected more often, is more painful, and may extend farther than a natural tear would. So many times, if somebody is really, not wanting to get across that they really don't want an episiotomy, what I see on their birth plans is that they would prefer to tear naturally. So that's normally what I would see. And again, you should definitely, talk to your doctor about it. It's not routinely done. So it's not something that happens all the time. All right, so I'll take your questions on everything that we've talked about tonight so far. I'm probably not going to get to all the questions because, like I said, I want to make sure that we get out on time, and we can answer more questions at the end of today. And I also want to make sure we spend adequate time on C-sections as well. All right, so someone asked, can you get medication or epidural after you have a fully ballooned place? Absolutely, yes, you can. And many people do because it is kind of uncomfortable. So you can get medications and or your epidural typically after you have the balloon placed, the one that we use for the dilating. I'm assuming that's what you're talking about. Can the forceps and vacuum hurt the baby permanently? There's always that risk with anything that we do. Any intervention that we do can hurt baby. It's very rarely used. And if it's used, usually the risk of harm from pushing the baby out is greater than the risk of harm from the vacuum or the forceps. So typically these are only going to be recommended if we really do need to get baby out quickly. So there's only medical indications for that. We do not just do that willy-nilly because of the risks associated. How much time can pass between the water breaking and contractions not starting before you should consider induction? So it's really going to be your doctor that's probably going to decide that you need to be induced, because typically it's not very long that they allow the water to stay broken and contractions not start. At some providers that, it's like 6 hours that they'll allow, and then you need to go to the hospital because, again, that risk for infection is very high. And then I have other doctors that will allow 12 hours before you can go into the hospital. But typically, it's not days, it's literally hours before we want contractions to start, just because of that risk of infection. Okay, someone asked, what are the most beneficial ways to prevent tearing? nice and slow pushing, not at the end, especially when baby is coming. We watched a video, I believe, in the last class, and she was talking about kind of holding her baby there. That really allows that tissue to spread and not tear. So if you think about it, if we're pushing really hard and really fast and baby's just barreling through, that's what's going to cause the tearing. Now, do not be afraid of tears. Tears happen, especially if this is your first baby. You more than likely are going to tear. It's just a part of the process. So the sooner that you accept that, the better your anxiety will feel about that. I tore with my first. So most mothers tear on their first babies. Um, so just FYI, it's likely to happen. So accepting that will benefit you more than trying to prevent the tearing. Now, pushing positions can help with that. Like I said, pushing on your side puts the least pressure on your perineum. But yeah, unfortunately, tears just happen. Okay, and then just because it wasn't discussed, elective induction would need to be discussed with your provider, but research doesn't really support elective inductions earlier than 39 weeks unless there's a medical reason. So just FYI, if you were planning on deciding to be induced yourself, that's usually not considered at all until you reach 39 weeks. Okay, so then the cesarean birth. This is surgical delivery of a baby through an incision in the abdomen and uterus. And this is performed if vaginal birth is not possible or safe for mom and baby. The reasons for a C-section fall into three main categories. You have your planned C-section, your unplanned C-section, and the emergency C-section. So the planned C-section. That would be for a mom who's having multiples. Twins can actually may be born vaginally. It kind of depends on your provider if they experience with that. If there's a medical condition in mom or baby, so this would be something like uh, placenta issues, or mom's blood pressure has gotten way, way too high and it's in fact affecting her organs. So we just need to get baby out quickly. We don't have time to wait for labor, or a previous C-section. Although TOLAC, which is the trial of labor after a C-section, may be an option to you, depending on the type of scar you had with your first C-section. But if you've had a previous C-section, a planned C-section can be repeated. So some reasons for a C-section would be for a breech baby. Now, there are doctors that will deliver a breech baby. They are very rare, but they do exist. So it's not an end all be all. Transverse babies, there's no way that can get through the vagina back first. That's unfortunately impossible. So that would be a C-section. And then placenta previa. And this is because the placenta is in front of the cervix. And this is an issue because that's your baby's lifeline. So babies are not mermaids. They're not breathing the water. They're getting all of their oxygen and nutrients and everything that they need from the placenta through the umbilical cord. So if that placenta comes out first and baby's still on the inside, that can really, really harm baby. It also causes bleeding for you. So it's not safe for you or baby. So placenta previa is a hard stop. We've got to have a C-section. Unplanned C-sections can sometimes happen for the following reasons. That's for abnormal fetal heart rate, if labor is not progressing, or baby moves into a position where a vaginal birth is difficult or impossible, or if baby's head doesn't fit into the pelvis, which actually is very, very rare. The biggest baby I've ever been attended a delivery for was 11 pounds, and that head was 16 inches. So just know, that the vagina can do some amazing things.
First-time parents Louisa and Jessie planned to have a vaginal birth. About a week after her due date, she still has not gone into labor. Her midwife scheduled an ultrasound to check on the baby.
A couple minutes into the ultrasound, we could tell that something wasn't quite right. She let us know that she was searching and she wasn't finding any fluid, that she was looking and there wasn't much to be found. And the midwife said, just go ahead and walk over to labor and delivery.
Louisa and Jessie go to the hospital and get settled in. Because of the low amniotic fluid, The midwife suggests they induce her that day to try to get labor started.
We'd hope to get it to thin out a little bit and open up a little bit, which means that we...
The midwife inserts a cervical ripening agent into her vagina. This is a tablet that will dissolve and help to open her cervix.
We'll still have a normal birth. She'll just have to be induced, which, isn't exactly what we wanted to do, but it'll still work out fine.
I was nervous and excited and also felt very unprepared. We thought we were just going to an appointment, and so I don't think I even brought my purse with me to this appointment. So we had nothing with us, and my meticulously packed labor bag was still at home.
Yeah. See you in a little bit.
All right.
Jessie goes home to get the hospital bag and then stays with Louisa that evening in the hospital. The next morning, Louisa is having very mild contractions.
Your baby's heartbeat's doing just fine.
But no real progress is being made.
Nice job breathing.
The midwife talks to Louisa about using Pitocin to help strengthen her contractions, and Louisa agrees. A few hours later, the baby's heart rate begins to fall, and Louisa is given oxygen to see if that helps.
Okay. What I want to have a very real conversation about is that this...
Because the baby shows signs of fetal distress, they discuss the possibility of cesarean surgery.
I think, honest to goodness, that our safest bet is to just have a baby. And by that, I mean, I think that we're going to need to have a cesarean birth here this afternoon, and sooner rather than later. Okay?
I just knew that, the most important thing was to have her safely, and the fact that she wasn't doing well made me feel like, okay, well, whatever we have to do.
Yep, we are going to have a baby, right? Right?
Louisa signs the consent form and is prepped for surgery.
Really cart thing for your stuff so that it all stays with you too. Yep.
Thank you.
Cesareans are performed in the operating room, and at least one support person is usually allowed to accompany the mother. Before joining Louisa, Jessie changes into scrubs because the operating room is a sterile area.
You ready, sister? Let's do this. Let's go meet your baby.
Her head's out. I told her when I saw her head, Sophia's head coming out, and there's one part where Louisa asked what was going on because she felt like a whole lot of pressure, and they were actually like pushing Sophia out, and it was just like crazy to me.
I saw Sophia for the first time when they were walking her over to the warmer, and so they had let me know that they would dry her off first because it was so cold in the operating room before they could give her to me. And then as soon as she was dried off, they gave her to Jesse, and he brought her over, and then the nurse helped put her on my chest after he brought her over.
Jessie and Louisa have a healthy baby girl who weighs 6 pounds and 11 ounces.
So another thing that you can do to sort of mitigate anxiety and stress related to an unplanned C-section is to have a C-section plan. If you're wanting to do, skin to skin in the OR, if you're wanting your, spouse to hold the baby, whatever it is that you kind of envision or best case scenario that you envision for this, you can still have a plan for that. Um, the other thing is they mentioned in the video that the baby was brought to the warmer. So immediate skin to skin is unfortunately not possible with babies that have C-sections, but we can get them to skin as soon as possible. Then the reason for that is not because the OR is cold, although that is one reason. It's because when you have a C-section, babies don't get that big squeeze that expels all the fluid from their lungs. So we take them to the warmer to make sure that they're transitioning okay and that there's not any fluid in their lungs and that they can breathe. So we take them to the warmer first, and then we bring them to either mom or dad or whomever is going to be doing skin to skin or holding baby in the operating room. All right, so emergency C-sections, those include these reasons. So that would be for cord prolapse. So if the cord falls through the cervix into the vaginal canal, that can easily be occluded. And remember, we talked about how that umbilical cord is the baby's lifeline to the placenta. And when they're not born yet, they're getting everything that they need from that umbilical cord. So if it's clamped, we got some problems. The other reason would be for a placental abruption, and that's when the placenta comes away from the uterine wall, again, prior to baby being born, so that is an emergency. And then there's uterine rupture, so that's when literally the uterus, for lack of a better word, busts open. And likely that likely occurs, that is one of the risks of um, C-section. So if you've had a previous C-section and then you're doing having a labor, you're subsequently laboring, one of the it's not something that's super common. You may hear somebody say that they had an emergency C-section, but it's more likely that they had an unplanned C-section. It wasn't necessarily an emergency. These four things are the only reason you would have an emergency C-section, and the way that you know that it's an emergency is because no one else would be allowed in the OR with you, because we have to get baby out within minutes, seconds even. So no one else would be able to go with you, and usually you're put to sleep. That's how we know it's a true emergency. If you weren't put to sleep and you were allowed a guess, that was not an emergency, that was unplanned. Cesarean birth anesthesia. So typically for planned and unplanned C-sections, we can use an epidural that's already in place. Or if there's no epidural in place, we can do a spinal block, which is similar to the epidural, except it's a in and out. There's not an epidural catheter that stays in. Or we can do something that's called a combined spinal epidural. So it differs on what space they use, but all of them will get you numb enough to be able to have a C-section. And then emergency C-section, again, they can use an existing epidural if they have time. If they can dose it really quickly, they can use it. I've not experienced that. However, usually if it's an emergency, we're using general anesthesia. So we're putting you to sleep so that we can get baby out quickly as possible. I think this video usually does not work. Yeah, it doesn't work. So how to reduce the C-section risk? So, if you want to avoid an unplanned C-section, this would be some ways to do that. So you want to enter labor in good health. So eat healthy foods and exercise. Prenatal yoga, prenatal Pilates, all those things are really good for you, especially for exhaustion. So labor is called labor for a reason. It is very exhausting. So then there's labor. So you should let your labor start on its own. Spontaneous labor is kind of the best way to avoid that. Stay at home during early labor. So staying at home as long as possible, because then you don't have all the interventions of the hospital. You don't have the lights and sounds. You can more easily get um, rest at home than you can in the hospital. So again, it's all kind of leading up to that exhaustion. Having continuous hands-on support is important too. So having somebody that can support you through your labor really reduces that C-section risk. So having a doula reduces your C-section risk. Using upright labor positions can also help. And then don't get your epidural until labor is well established so that you avoid the chain of intervention. Because usually, once you get an epidural, then you got to have IV fluids, then you got to have Pitocin because your labor has slowed down, and that's kind of the chain of intervention that can happen when you get an epidural. So wait as long as possible if that's in your plan. There is a such thing as family-centered C-sections, and includes things like asking to have the screen lowered to see the birth. These are things that you can include in your C-section plan. Even if it isn't your plan to have a C-section, you should still have a plan C. So you can ask to have the screen lowered to see the birth. You can use prepared childbirth techniques to relax. And that prepared childbirth is like it focuses on breathing and things like that. So I highly recommend you take an in-person class if you're wanting some tools to relax. We just don't have enough room in this class to put it in. Have photos or videos taken if permitted. Hold or touch your baby while your surgery is being completed. So you can see that baby is skin to skin. Sometimes in the OR, depending on like how you are on the table, we might have to do cheek to cheek, but even cheek to cheek is still skin to skin. hold or touch your baby. Oh, sorry. Skin to skin is an option, and dad or support persons can also do skin to skin if mom is nauseous or is kind of has anxiety about doing skin to skin while being operated on. Anybody can do skin to skin. And that goes for even outside of a C-section. Anybody can do skin to skin. I know when I had my second, my whole family did skin to skin. My husband, my 2-year-old, everybody did skin to skin. And then you want to breastfeed as soon as you can. And so that typically does not happen in the operating room. Usually that will happen in what's called the PACU. So after you've had the surgery, they'll move you into a room where you'll be monitored. Um, Typically, it's a multi-person room, but you'll be in that room, you'll be monitored, and that is when the nurse will help you to breastfeed. So the advantages of a C-section is that it is a life-saving procedure if vaginal birth is unsafe. It's quick and it's a relatively safe procedure. The disadvantages is that there is a higher risk of infection, blood loss, hemorrhage, and blood clots in the legs, longer, more painful recovery, and there's a high risk of emotional trauma or perception of a negative birth, especially if it wasn't in your plan. The disadvantages to baby are breathing problems. Like I said, they're not getting that big squeeze through the birth canal, so they're not getting all that fluid out of their lungs. So sometimes we have to help them. That's why they go to the warmer first. Low APGAR scores. So the APGAR score is a scoring. We literally are grading your baby the minute they are born. And it looks at things like skin tone, the tone of their limbs. So are they clenched? Are they extended? Are they moving their arms and legs around? Are they crying? Um, we look at all these various things, and it goes up to the score can go up to 10. If your baby is above 8, we're doing good. 8 and 9. Usually nobody gets a 10 because most babies have purple hands. So we'll talk more about what baby looks like when they first come out, and it might be kind of surprising to you, but usually babies lose points for having purple hands and feet. And that's because their circulatory system is immature and blood flow just hasn't quite gotten to those yet. Their babies are really smart and they know that their brain and their heart and their organs in their trunk are more important than their hands and feet. It will go away though. And then injury as well, and that's rare. Okay, so questions on the planned or unplanned C-sections. Reason for emergency C-sections. Remember, those only occur in 1% of births. Anesthesia, reducing your risk, or what you can expect. I'll mute myself and give you some time to put your questions in the chat box. Or this is our last section of the night, so if you have any other questions on what we've talked about, you can place those in the chat as well. Okay, got a couple questions. Let's see. Why do some hospitals not allow the birth to be videotaped? It has to do with hospital policy and I believe like liability. It's not necessary. I don't really know like why it is, but if they have that policy, I mean, I would ask them to see it so that you can see why. But it just has to do with the hospital's policy that you can't video. Not exactly sure why it is that way, but my guess is it has something to do with liability. How long before the epidural wears off and you can walk again? So usually about 2 hours. So like I said, we will if you've had a vaginal delivery, we'll turn it off after all the pushing is done, baby's out, placenta's out, repair is done. We'll turn it off, and it usually takes about 2 hours before you can get up and walk again. Now, if you've had a C-section, however, it's usually more like 6 hours before you can get up and walk again because we've used a lot stronger medications. Um, and so it just takes some more time for that to wear off. Okay, it looks like we actually made it to the end on time. Like I said, I'm going to stick around and answer some questions for you, though. How long does it take for C-section repair to be done? So for a C-section, usually it's a very short procedure. It's only 30 minutes to an hour. Some providers are even faster than that. So it's very, very quick. And you're awake the whole time as long as it's not an emergency. Okay, so if you don't have any more questions, I'll go ahead and let you go for tonight. And I hope I see you next week. We're going to pick up right where we left off and talk about baby. I hope I see you next week. And if you have any questions, I'll leave the chat open for a little while. Like I said, now I'm not going to be answering the questions out loud. So make sure you include your email or phone number if you have questions so our team can get back to you.